And so, first of all, again, welcome you all who is joining from all over the world. This session is part of the 2025 ECOSOC Youth Forum under the theme Youth at the Forefront, Leveraging Science and Social Inclusion for Sustainable Development. So today we'll explore a powerful and urgent topic, youth mental health in India, and how youth-led innovation can drive meaningful, sustainable changes. Just to let you all know that we will be recording this session. And my name is Yanxin Liu, and I'm currently a Master of Social Work student at Columbia University. I'm currently doing a social work intern with TYCL International. I'm very honored to be your moderator for today's site event, and which is youth-led mobile mental health clinic, addressing accessibility and affordability gaps for sustainable community well-being. And so now I will hand it over to our speakers to let them introduce themselves to you all. And today you will hear from the inspiring people who designed, implemented, and evaluated this work. So Dr. Shiva, would you mind taking the lead?
Thank you, Yanxin, for your leadership and coordination on this event. And my name is Siva Mathiyazhagan, and my pronouns are he, him, and his. And I'm the founder, director of Trust for Youth and Child Leadership based in Pondicherry, India, and New York, USA. And I'm also serving as an assistant professor at the School of Social Policy and Practice and University of Pennsylvania. And over to Kartika.
Thank you, Dr. Shiva. Hi, everyone. Thank you for joining us. My name is Kartika Kelly. I am a social worker by profession, working more on the macro level. I'm also the grants manager and board liaison at Help for Children. It's a grant-making foundation that gives grants to child abuse prevention and treatment, intervention, and research. I have also been a volunteer research and evaluation associate at TYCL. Very proud to be part of the wonderful work that TYCL has been doing, and I'm glad to be here. I will hand it over to you, Adithya.
Hi, first of all, thanks for having me on this platform. Myself, Adithya. Is it audible? Program coordinator who's coordinating the mobile mental health clinic in TYCL India. I'm social worker. That's it. I would like to hand over to Ms. Sakshi.
Thank you, Adithya. I'm Sakshi Shah. I'm also a licensed social worker. I work at North Suffolk Community Services. I'm currently doing community-based mental health. I was a social work intern at TYCL, and I had the opportunity to go to Pondicherry and be there for a couple of months and work directly on ground with the mobile mental health clinic program, which was a very exciting opportunity and got to learn a lot. You will hear more about it in this session. And yeah, thank you, Kartika and Yanxin, for putting this event together. Welcome, everyone, and very glad to be here. I'll hand it over back to you, Yanxin.
Great. Thank you all for being with us today. Oh, and we will also leave this Zoom room open for about 10 minutes after everything is over, just in case if anyone wants to connect with someone in the room. So let us get started. Let me begin with a brief background to frame our discussion. So in Puducherry, India, suicide among youth has remained a critical concern for over 2 decades. In 2022, Puducherry ranked third in the country with a suicide rate of 29.7 per 100,000, more than double the national average. Research points to key risk factors like socioeconomic status, rural residence, stigma, and lack of access to mental health care. Especially in rural communities, mental health literacy is very low, and modern treatment is unfamiliar, and societal stigma remains very strong. In response, the TYCL has launched the Mobile Mental Health Clinic, MMHC for short, a youth-led initiative that brings culturally relevant mental health service right to people's doorsteps. So, using outstretched storytelling and trust building, the MMHC bridges critically gaps in affordability and accessibility. Recent evaluations shows that the program improves knowledge, reduces stigma, and is overwhelmingly supported by the community. Oh, and also this discussion is also crucial in the context of achieving Sustainable Development Goal 3, which is ensure healthy lives and promote well-being for all at all ages. While significant progress has been made globally, such as reductions in child mortality and improvements in HIV treatment, persistence in inequality and setbacks, especially after COVID-19, continue to challenge access to quality healthcare. And youth suicide and mental health crises are emblematic for broader issues in achieving universal health coverages, particularly for marginalized and rural communities. So as such, programs like MMHC plays a crucial role in moving us closer to the target of SDG 3 by ensuring access to essential health services, addressing stigmas, and promotes community-based care. And that's it about the background. And now we'll move to hear the Dr. Shiva's presentation. He will be introducing TYCL's broader youth-led community actions and its commitment to the SDGs.
Thank you,
Dr.
Yanxin.
Shiva, over to you. Oh, sorry.
Thank you, Yanxin. Hello, everyone, and welcome to our ECOSOC Youth Forum TYCL's side event. And as Yanxin was introducing that, TYCL's started everything from Puducherry, India. It's a small coastal town and in the east coast of the Bay of Bengal. And TYCL was founded in 2011 when myself and then few of my friends from Pondicherry University, when we are like studying and then encountering like so much of like youth challenges in Pondicherry, and what are like something we can be done as a responsible youth, or whether we want to spend our time in elsewhere or like giving back to the society. So that's how this whole initiative is kick-started. We piloted for a couple of years, and then we officially registered in 2011, and it started as a youth-led organization. Now the third generation of youth-led initiatives are going on in Puducherry itself, and then we got expanded our initiatives. And in 2018, we received a ECOSOC consultative special consultative status with ECOSOC at the United Nations, and that enabled us to have like the event like this, including and then making like youth voice heard in the global forum as well. And we continue to practice at the grassroots level and ensuring safe, inclusive, and participative spaces for young people to express their feelings in a much more safer way, where they can feel safe, and then their mental health and mental health and leadership needs are met. And always we expecting young people to take a leadership role and engaging actively in the programs, and then that program model, young people can come as a volunteer and intern, or like and then take up a leadership role and coordinate the program and serving as a coordinator, and then move towards like a leadership role. Most of our current board members are started as a volunteer and then become a board members of the organization itself. So that's a kind of like a leadership approach we look at it. And almost 100% of the organizational board and then operational members are first generation graduates, and coming from low and middle income family situations. And we have like a co-designed and developed like a variety of programs, including a youth helpline, which was like started as a first ever program to address the mental health needs of the young people in Pondicherry, because when we looking at the data sets back in 2012, Puducherry had a highest number of suicide in the world, which is like a 4 times higher than the national and global average. And one of the major, like almost like more than 60% of the suicidal deaths from the youth. And when we are looking at it, like, we have a highest number of education institutions, and then like the lowest number of job opportunities and career are related. And then socioeconomic determinants are playing a vital role, but there is no such interventions are available. And then the conventional approaches in the government systems are not really reaching the needy young people. So then we need to have like a more creative and alternate intervention models has to be developed and implemented. So we integrated a youth leadership model as a mental health intervention approach for us. So if you are giving like a more opportunities, socioeconomic and leadership opportunities to young people, and then how that's helping them to improve their mental health. And our youth helpline has been running for like almost a decade now, and we offer counseling services, and we also have like a job assistance, career guidance, entrepreneurship support, internship opportunities, and there's like a variety of programs, outreach activities that happens within the youth helpline as well. And harvesting, we do like harvesting youth leadership and International Youth Day and suicide prevention day programs. And one thing which we learned over a period of our implementation process, the triggering element within the mental health interventions in mental health determinants, the caste and gender disparities and discriminations happens at family level and the community level, as causing them like a lot more at the institution level too, and causing them a lot more mental health challenges for the young people. So we initiated the Girls Lead Girls, a holistic self-defense program, and as well as the positive mental health, positive masculinity for boys and young men in the community. So that like the gender justice initiatives can be integrated into the mental health intervention as well. And in order to engage the youth constantly, we have a variety of program. And I think like Adithya will explain more about our mental health community mental health clinic, and then our camps and other activities happening within the TYCLs focused on the mental health interventions for young people. And we are like very grateful for our partnerships and collaborations, particularly for Mariwala Health Initiatives. And without their support, like this kind of like community-based youth-led interventions are not really possible. I know that like when we are like going through a lot of your questions, and then you are asking about like how as a youth-led organizations can raise the funds to sustain your activities, and how do you manage and how do you can be a culturally sensitive and culturally responsive to this. So these are the like some of the challenges which we encounter in the early stage of our organization as well. And one thing which is like a strongly we believe in how our programs can be ethically, legally, and logically driven by the youth, and particularly the local youth, then you'll be like addressing the most of those issues. When the funding comes, when the real work and evidence-based practices are happening at the grassroots level, when you are disseminating at the right spaces, I think the funding possibilities also open up a new door for us to make these programs a reality for young people in the communities. I think I'll pause here, and then when the questions are coming up, I'll maybe address more. And in terms of like maybe like a quick status of the youth mental health, I think Yanxin has covered a lot more, and I want to give a little more global perspective about what is really happening at the global level. More than 77% of the global suicides are occurred in low and middle income countries, particularly in Asia, Africa, and South America. and an average 40% of the mental health patients and help seekers have to travel at least more than 10 kilometers, which is like 7 miles, to avail a mental health care. And so the resources are very, very low, and WHO highlights that like only 2% of their mental health budget, health budget is covering the mental health. When it is come to the youth mental health, not even a 0.5% of the budget is covering the youth mental health. So there's like a very clear need for a global advocacy, particularly for the from the global south, has to happen, and significant resource allocation has to happen from the states, within the states, within the countries, and then like all the countries across the global south has to come up with like a stronger advocacy and a stronger initiatives to have a sufficient resources allocated for the youth mental health, so that these initiatives can be taken, and then youth can lead this mental health intervention at the grassroots level much more stronger and better. And thank you for this opportunity. And then like my big gratitude to Kartika, Yanxin, for a leadership role they're taking. I don't know how much time I'll get it after this. So let me convey my gratitude for them. If without their initiatives, this event wouldn't be possible. And thank you once again.
Wonderful. Thank you, Dr. Shiva. And if any of you have any questions, feel free to drop them in the chat. We will have a Q&A session at the end, so we will answer every question that were in the chat over there. And now Ms. Adithya will walk us through the mobile mental health clinic itself, its goal, its strategies, and how it's going to make a difference for youth at risk of suicide in rural Puducherry.
Hi everyone. Okay. From the beginning itself, I'm like, maybe people will be curious about what is mobile mental health and how the youth is handling this in the community level. Basically, as both of us, Dr. Siva Mathiyazhagan and actually mentioned, we collect reports from NCRB and RTF from local administration, and the suicides which has been reported in television news and newspapers. All these data have been combined and analyzed together, and we will prepare a chart according to the area which has more youth suicide, and it will be prioritized. Also, while doing this risk mapping, the cause for suicide has also been identified, which majorly seen as the family issues, relationship issues, substance abuse, alcohol dependency, financial issues, and unemployment, and there are a few more. To address this, to address these rising concerns around youth mental health and suicide, TYCL launched this Puducherry Youth Helpline with the aim of reducing suicidal risk by offering 6 services like counseling, job assistance, career guidance, entrepreneurship support, education loan assistance, and volunteering opportunities. This initiative also informed by data revealing that youth in rural communities face a disproportionately higher rate of suicide, often due to limited awareness and poor accessibility to mental health services. This helpline seeks to bridge this critical gap by creating a support system that is more comprehensive and accessible, especially for marginalized and underserved population. By 2020, TYCL launched this mobile mental health clinic, a community-based initiative to reach rural communities across Puducherry and to raise awareness about the importance of mental health. This initiative aims to sensitize communities about TYCL services, including Puducherry's youth helpline, and to make the mental health support more accessible at the grassroots level. A dedicated team comprising of mental health professionals and a coordinator with the trained volunteers visit these villages directly twice a week, engaging with people at their doorsteps. They distribute this informative pamphlet, including our helpline number, and communicate this mental health concept and available services in a socio-culturally relevant manner, where they can understand more easily, and they will connect with us. Through this approach, TYCL strives to build trust, reduce stigma, and connect youth to life-changing opportunities and support system. if in case they need services on the spot, our mental health professionals will provide this counseling on spot where they are convenient. As an extension of this mobile mental health clinic, TYCL initiated community mental health camp in 2023 to deepen the outreach and support for rural population. This is a one-day long camp using the same mapping approach, suicidal risk mapping approach to identify the community. In this camp, a psychologist and a social worker come together to offer the mental health services. Uh, offer this mental health services. Also, before this one-day whole day camp, recognizing this stigma that exists in our society, TYCL adopts multi-layered awareness strategy to ensure ongoing engagements. Awareness is not only limited in a single effort, but it is also carried through a pamphlet distribution, public announcements, and visual performance such as street play. To make this intervention more effective and locally relevant to, like, as it is mental health, people sometimes hesitate to directly come to us and approach us. So we'll identify a key informant from this particular village who, like, pretty much know about the people and their behaviorals. So that person will help us to identify who are the individuals who are in need of mental health services, and like what kind of requirements are needed through this process. So by that we can easily, like, target the population. Also, this is not a one single day camp. To make the people like understand what we are doing and make the people like to calm themselves, we'll also provide a follow-up camp in a following week. So if the people might hesitate in the first day of camp, they can turn out in this the follow-up camp. So this is also a part of our mobile mental health clinic initiative, and this has been like successfully. We have covered more than 10 villages so far in from 2 communities. So this is all about this our projects.
All right, thank you so much, Adithya. And next we will hear from Ms. Kartika, who will share insights for MMHC evaluation study.
Thank you, Yanxin. Yeah, so I will be talking about the study that we conducted initially for this mobile mental health clinic program what we wanted to achieve is that we wanted to understand the current mental health knowledge, attitude, and practice of the participants. And we also wanted to understand how the implementation took place in order for us to be able to get informed decisions for subsequent intervention strategies. So for this study specifically, we took a sample of 10 service recipients of the MMHC program, and also 11 key informants. These people are teachers, local health clinic workers, and also community leaders, as well as 5 staff members and 4 volunteers. In terms of the research methods, we used a mixed method consisting of quantitative and also qualitative approaches. For the quantitative data, we use the KAP model. Some of you might have been familiar with the model. It's basically knowledge, attitude, and practice model to assess what one knows or their knowledge, what one believes, or their attitude, and what one does or their practice, in this case, in relation to mental health. And once we gathered, for the qualitative data, we used live story interviews and also focus group discussion. Once we gathered all the data, the analyses that we conducted were a correlation analysis of the KAP mean scores of the participants and also their demographic variables. We also did a thematic analysis of the interviews and also focus group discussion. And we also wanted to know the sentiments of the participants on how they view the continuation of the program. I will just run through the results quickly. So this is the mental health knowledge, attitude, and practice scores. What we did was actually categorizing them into 4 different categories. The low category is under 25th percentile. Between 25th and 50th is lower moderate, upper moderate is 50th to 75th, and the high category is above 75th percentile. As you can see from the results here, that the majority of the participants fall under the high or upper moderate categories in their mental health knowledge, attitude, and practice. So I think this is good results because only a very low percentage of the participants was on the lower moderate, and we also had some who did not answer the questions. However, one caveat that I would like to share is that we did not have a baseline data to compare this with. Therefore, we could not really draw any conclusion whether the program was effective or not, but we did collect this data, and hopefully we can use it to integrate to a more longitudinal study over time in the future as we continue to implement the program. For another quantitative result that we did this correlation analysis. As you can see here on the table, we found that Dr. Shiva had mentioned it briefly earlier, that caste and gender, they had a correlation with mental health knowledge and practice. This also aligned with previous research, although in this particular study, we had a sample of disproportionately individual who identified as female. So hopefully we will have a more diverse sample in the future for us to be able to explore this caste and gender correlations better. So I'll move to the qualitative results. Basically, based on the interviews and also focus group discussions, we found 2 overarching themes. The first one was themes related to barriers to accessibility, and also the second one is barriers to affordability. So what we found under accessibility, the barriers consisted of information gaps. These were in relation to whether they knew or not that such services existed, how to locate them, what the associated costs to obtaining them, and what other hidden costs, in order for them to obtain the services. And aligned with previous research, we also found that stigma is a significant barrier. And in our case, this stigma actually comes from people seeing mental health, someone with mental health problem as weak or inferior. And they also have invalidating environment where, for example, parents did not want their children to disclose their mental health struggles, let alone seeking help, because they fear of judgment. They fear that it might affect their social status, or they might lose respect from the community. However, what we found, and we believe is still underexplored, is the issue of mistrust as a barrier. We found that mistrust specifically stemming from familial and societal neglect and mistreatment as a barrier to access services. As an example, in our interviews, we found that a lot of female participants reported being neglected of their basic needs by their spouses or their in-laws or their direct families, or they receive mistreatment such as psychological abuse or verbal abuse because they had relationship issues. Some of them were also associated with, Adithya also mentioned it, alcohol abuse, substance abuse, and also just familial conflicts or relationship conflicts. In terms of societal neglect and mistreatment, some participants reported having experienced being scammed and losing money. A lot of people came to them disguising as an NGO, a credible NGO, offering job assistance, and they took money from these people. So it was a barrier for the MMHC team to approach these people to build rapport and eventually build trust and obtain services from TYCL. In terms of affordability, we found that people did not want to access or had limited access because they're afraid of or not knowing the cost of services and also associated costs such as transportation costs. However, one participant stated that as long as the services are provided for free, people would definitely take advantage of that. The last result that I want to share is about the sentiment. As I said earlier, we did not have a baseline data, so it would be useful for us to know the sentiments of the participants to inform our future implementation. So here we have the result that about 3.45% of the participants just said that they had a neutral sentiment because they were only recently exposed to the program and did not use the services yet, so they didn't have much to say about it. However, 6.9% of the participants had negative sentiments because they were not confident about the continuation of the program if they only focus on rural populations, as well as in terms of the funding, because the services are provided for free. However, almost 90% of the participants, they were positive about the mobile mental health clinic, being a continued program because some of the reasons that they mentioned, because they regarded it as an additional crucial resource beyond their familial and social support. They also feel confident that the program could help destigmatize mental health. They were also concerned about the prevailing poor mental health in the community, so they saw the need for ongoing support. And they were also impressed by the team's dedication in making sure that the community is aware of the suicide issue in Puducherry. That's all that I would like to share. I will hand it over back to you, Yanxin. Thank you.
Thank you so much, Kartika. And again, if you all have any questions, feel free to drop them in the chat. We'll answer them in the Q&A session that is coming up. And now Ms. Sakshi will speak to us about MMHC, reflecting on the challenges youth face in accessing care and how these experiences can inform future research and practices.
Thank you, Yanxin. So I will go into the challenges we faced with the research and the limitations, and then the implementation challenges with the mobile mental health clinic. Kartika touched upon some of these, but with the research specifically, as Kartika mentioned, due to the unavailability of the baseline data set, because we implemented this program during the COVID-19 pandemic, so we prioritized immediate care delivery over collection of pre-participation baseline data. So that was one of the limitations. However, we hope to continue this as a longitudinal study and longitudinal analysis over the next few years. And then the second challenge was the limitation with the generalizability of the findings to the broader population in Pondicherry, because as Kartika mentioned, we had a limitation with more female participation for this study specifically. And in terms of the implementation of the mobile mental health clinic program, one of the big things that we've been talking about is sustainability and funding for the program. So as Dr. Shiva mentioned, Mariwala Health Initiative is one of the organizations that has been supporting this program. However, that continues to be a challenge, especially because it's a youth-led initiative. And so here, the recommendation, hopefully, as Dr. Shiva mentioned, is that there could be more policies around funding. So, for example, the Mental Health Care Act of 2017 in India, Pondicherry was not mentioned in the act. So, some policy changes around that, where there's more funding towards youth mental health initiatives. Another implementation challenge is, as Adithya mentioned, we have volunteers that go into the community, and these so having stipends for the volunteers could help with more retention of volunteers. So that becomes a challenge with the implementation of the program specifically. And in terms of future research and recommendations, as Kartika had mentioned, we hope to further do research and investigate into the mistrust that she talked about, and the role of mistrust as an additional barrier to mental health care access. And in terms of the implementation recommendation, hopefully we can train more staff and volunteers to tackle the mistrust in the communities and the stigma around mental health care access. And in terms of the policy level recommendations, we can collaborate with the government. So combining the mobile mental health clinic with the Pondicherry Youth Helpline, which could make it more focused in terms of support and can bring in more government funding as well. Yeah, I'll hand it over to Yanxin.
Great. Thank you so much. And once again, I want to thank you all to our speakers for those rich and moving presentations. Let's give them a big pause. And we now have time for questions and reflections for the audience. And please feel free to type your questions in the chat. We'd love to hear your thoughts. Oh, I see one question popping up. The organization aligns its programs with local school to spread the awareness around the mental health care.
Yes, Aditya, you want to take it up? Or so yes, there's a constant outreach activities are happening at the schools and colleges across the Puducherry, and we do have a official permission from Puducherry Education Department for higher education as well as the school education to run our awareness programs in the schools and colleges. So that's one of the way we reach out to the schools and colleges and then try to implement, try to sensitize the community about existence of the program and how young people can reach out to the youth helpline or mobile mental health clinic, or even if they can request a very specific services, as well as we have set it up 3 counseling centers in 3 different colleges where we have noticed the high number of requests from the colleges side. So that's I think our mental health service providing team goes once a week to each of these colleges and then listen to the young people and their needs, and try to address it at the institutional level as well. Aditya, you want to add anything?
Yeah, sir. As you mentioned, also we get requests based, especially from schools, like on the adults and mental health. Will turn out to us and ask for we need sessions on this. So through the cyber world, we are providing mental health awareness through CSO. That's it.
We also have other allied activities, like including one for Girls Lead Girls, which is like a holistic self-defense program for girls, in particular in educational institutions. That particular program, we have a holistic approach. The conventional self-defense programs covers only the physical and sexual element of the self-defense, but our program, which has like a holistic approach of emotional self-defense and intellectual, socio-cultural, and economic and legal elements into it. So when we are going and doing that training programs into the colleges, it goes with the integral sensitization for emotional well-being of girls specifically. And similarly, our positive masculinity for young boys and men program also has the integral elements for the mental well-being of young people. So there's like all our allied activities. For the children specifically, we also run a program called Online Child Safety and Digital Citizenship Program for children in the schools across Puducherry. We have permission to do the program in all the schools in Puducherry. So in that program also, emotional well-being is the other key component, where we try to integrate all our programs, critically integrating the mental well-being of young people into every single initiative we take.
Great, thank you. And here's another question. Does your program also reach out to families of the youth, trying to educate them so that they understand the youth better?
Who wants to go?
I can go first, and then all of you can add that. Yes, definitely, because we go to the commune where the youth live. So we talk to the family, and it depends on who's available at home. Then that's the people that we approach. However, if our targeted populations are youth, they're not home, we also share pamphlets. As you can see in the video, we share resources where they can reach out to obtain the services. So our idea of a comprehensive approach to mental health services is not only targeting youth, but we also want to include the people in the youth's lives, because as you heard earlier, I mentioned about how families create invalidating environments, and we want to tackle that as well, so that it's a safe environment for everyone, and the awareness goes beyond just the youth, but also the people who often also make decisions on behalf of them, such as parents or people with authority.
Aditya, you want to give a little sense about like how many families in a year we reach out of our outreach activities?
As it is community, we cannot only focus on a particular target group. Like we cannot only focus on youth. It's a mixed, like we'll reach out to children, we'll reach out to the elderly people, and the way we communicate is like much simpler way. And in a year, it's like maybe no one in a month we will be reaching out more than 500 families, more than 500 to 800 families. Like it will be like totally 8 outreaches in a month.
So on an average, we reach out to at least 4,000 families in a month. So which is like accumulation of like over a period, we'll like have 10,000 to 12,000 families get benefited get sensitized out of this. And then even if they're like some of the households, if they are not present at home, then we try to make sure that like they get the pamphlet or communication materials, so once they come back, because the livelihood. And also one of the other key strategy which you use, like our outreach activities takes place whether in the early mornings or late evenings, so that the people are present at home. Most of the families may not be present during the working hours. Both of the household members out of the home, and then students, youth members maybe work in the colleges or academic institutions or at the workplaces, so they may not be available. So our program has to be remodeled based on the the family members availability at the community level. And during the working hours, we go to the colleges and make the presentation so that there are youth members directly available there. And also when we are trying to target about like which community we want to go, as Adithya was mentioning earlier, every year we constantly do the media analysis and how many suicides are locally reported and how and then where is exactly happening, and then we collect the data from the local police stations and then like a local crime record bureaus, so where exactly happening, and NCRB data, National Crime Record Bureau data. So we accumulate all this data and then we have done a complete mapping of highly vulnerable areas within the Pondicherry. So every time we pick a community to go and do this, it's based on the high risk communities, which is like informed by our data sets. So that's like one of the evidence based model which we try to target the a specific community. There was some of the other questions came up around like how do we ensure the cultural sensitivity and catering to the basic need of the people. The one way is all our communication materials are bilingual. It's in Tamil local language as well as in the English. So so it's just bilingual communication materials are available for the people to access quickly, as well as our model is not like a conventionally giving us okay, you can come to our counseling center, or you'll be going to a psychiatric care. How do you try to understand the clear socioeconomic and cultural needs of the people, and then trying to be with the community and then trying to address that specific needs. Like for example, most of the last year, most of our calls, almost 65% of the calls for job and job assistance related questions and assistance request. So the economic crisis constantly putting young people into the mental health crisis. So our our referral systems are our economic support system model catering to the specific need of the young people, and also is customizable for every individuals. It's not about a one model fit for everybody, and then how we can try to understand. Sometime it's also attached to the family issues, and there is a multi-fold and multi-factor influences such issues. So we need to dismantle those things and then specifically address those needs. Helps us a lot in gaining the trust we wanted to work when we wanted to work with the communities, particularly with the young people and their families.
Great, thank you so much for your answer. And I have received a text that they'll come off mute and ask their questions. It might be easy for them. So
Thank you so much, Yanxin and the rest of the TYCL team. First of all, thank you so much for this session. It has been very, very informative, and that's an impressive work out there. Learned a lot. I think my question is, I might have missed this because I went offline in between. So when you told about the lack of baseline data to measure the research results with, and I just want to understand, in spite of knowing the needs of the community, in spite of knowing the high-risk areas in the community, and after that launching this, what was one crucial data that was missing for you to estimate the impact of the mobile mental health clinics? And in the way forward, what are some of the things that can be, what are some of the indicators that can show it very clearly that the impact has actually created a shift?
Kartika, you want to start with that? I can go with that. It's easy. Kartika, go ahead. You've been reading the research part of it. Kartika.
No, I mean, we can both have our thoughts on it. So yeah, the lack of baseline data, ideally we want to measure the pre and post intervention so that we know whether there is an improvement caused by the intervention. So that's what we are not able to conduct in terms of the analysis. However, we are interested in knowing the trend over time, which we will do because right now the program is still taking place and we're still collecting data. So that's our plan moving forward in order to address the lack of the baseline data. But I think like we were in a good place because we, as Sakshi mentioned, we rolled out this program during the pandemic. Our priority was not to collect baseline data, which could be like time consuming. So we wanted to make sure that we deliver the services as soon as possible because the community needed it during the COVID-19 emergency. So we, like the baseline data was not as important as making sure that the services were delivered. However, I want to also emphasize that although we do not have the baseline data, we have previously conducted our evaluation on the Puducherry Youth Helpline program, and we're informed based on what we collected then. And we knew what the determinants of suicidal ideation among the community, especially the youth. So informed with that findings from the previous data, this is how we approach the mobile mental health clinic. I'm also going to share the Puducherry Youth Helpline paper if you're interested in reading more about it.
Also,
Share it in the chat.
to add on to that, with the absence of this pre-intervention baseline data, the sentimental analysis that Kartika talked about, it can inform subsequent mobile mental health clinic strategies, and also we can learn more about support-seeking behaviors of individuals through the ongoing programming and data that's being collected.
So basically, this program, not having a baseline data, we wanted to acknowledge that as one of the limitations because of, the conventional academic requirement. It's not like really we wanted to like see this as a weakness, or the program is not effective, or basically, the Eurocentric, the research approaches are pre-requesting such requirements, so that we are also submitting to the mainstream journals of this work. So we wanted to make sure that how we acknowledge our own baseline data, which is the lack of baseline data. And but as we have done enough need assessment, and we knew that exactly what need to be done at the community. If we are looking at as a positioning ourselves at a interventional study right now, which is not an interventional study, and it's just evaluation of our program. So and so when we are evaluating the program, we wanted to make sure that how we can bring some of the conventional scientific approaches, as well as how we can bring some of the innovative research explorations as well. So also how do we adapt some of the indigenous models and approaches to integrating or blending the youth work. Sometimes when you are initiating a community need and the research requirements are never meets together, because by the time we get IRB approval from the board or anywhere else, then that the need is disappears in the community. So that's some of the challenges which we continue to encounter on the conducting a research and implementing a program based on the community need. So in terms of the future directions, as we mentioned that we wanted to go as a longitudinal study where we can continue to observe the patterns with the data we collecting from our own participants, as well as looking at the national and the state level data, and then comparing them, and then whether we are going in the right direction or not, the program is impactful. So when I was starting this conversation, when we started this whole helpline, the Puducherry suicide rate was 4 times higher than the national and global average. Now we have a 2 times higher than the national and global average. So which has there is a reduction, but we can't take a complete ownership of this outcome, but we are significantly contributing to the contributing to the reduction of the youth suicidality in Pondicherry, because there is no other additional programs implemented by any other organizations, or no additional interventions given by the any other institution, government or private institutions as well. So which is like, providing and then collecting the grassroots level data, as well as like collecting the meta level data from the state and the central information bureaus. So those things is like validating that like this can be done. And one of the key element for us continue to be evidence-based practices, whether like, whatever the approach you are taking, and then make sure that it meets the local people need, and then locally the model is locally recognizable by the people, and that validates whether we can proceed or not. I think our research approaches can be as innovative as possible and as open as possible, like adopting much more indigenous research methodologies, which will be much more effective, and then like doing a conventional. So we try like, in other elements, like, when we are not submitting our own work to the conventional research journals, then we open up like our own perspective pieces and then our own open models to the other platforms, like, the recently the Zen, which we are able to identify, what is a culturally responsive healing science would look like, how we can able to do this in a much more consciously to meet the local people's need. So there are like a significant work has to be done. We are in a very, very early stage of this process. We are also like constantly learning from the every stage. We have like a critically reflecting our own work in a within the internally as well as with the external members, and taking this feedback. If you have like any good feedback or like constructive feedback for us, or if you have an opportunity to collaborate together, we are open and then willing to do this together with people around the world. As well as if you're learning something new, and then if you want us to take this model or like somewhere you want to try to implement it, we are also happy to provide the resources and support system to take this model further to scale up. Thank you.
Great, thank you so much. And it is 10:01 over here, and I think it is probably time for us to wrap everything up. And so as we
Just
come
make
to
sure that if anybody have any other questions before we wrap up, and
okay.
and also give
I
them a
don't s-
time for a networking if the people want to get together casually after off the record.
Definitely. Yeah. I don't see any questions in the. Wait a sec. Yeah, I don't see any questions in the chat now. So, and yes, we'll have time. We'll have the Zoom session open for about 10 minutes, even after everything's over, for everyone to connect. And so, as we come to a close, I really want to thank you all for your wonderful speech and presentations, and also your tireless effort in improving youth mental health, and to all of you in the audience for participating in this vital conversation. The mobile mental health clinic is more than a service. It is a model of hope, driven by youth, for youth, and rooted in community care. It shows us what's possible when we combine lived experiences with innovative grassroots actions. So let's continue working together across disciplines, borders, and generations to build a world where every young person have the access to the care and support that they deserve. So to learn more about TYCL, please visit our website or follow us on Facebook, LinkedIn, or Instagram. I will put this in the chat for those who kind of joined me a little bit late. And again, thank you all, and I wish you have a powerful and inspiring rest of your EcoSoc Youth Forum. And yes, we will have this Zoom open for about like 10 to 15 minutes.